You should see the little message that there it goes. All right, well, welcome everyone. We are here to talk about psychiatry, and we have Dr. Brandon DeLiberato, and he is a board-certified psychiatrist in psychiatry and neurology, and he joined BayCare back in 2016 as an inpatient psychiatrist, but now he's our medical director over our child and adolescent service lines. Before joining BayCare, he was the chief psychiatry resident at Cleveland Clinic, but he has made a big impact on BayCare. BayCare is one of the largest behavioral health full-service community-based healthcare systems in the Tampa Bay area, and it offers a wide range of comprehensive services for mental health, addiction issues, and it's tailored to meet the needs of children, adults, and their families. With more than 10 years of diverse experience in psychiatry, he has a dedication and attention to the patient's care that makes him the perfect fit to advance BayCare's mental health services here at BayCare. So I am going to turn it over to you and let you share. Thank you.
All right. Good morning, everybody. Thank you so much for having me back. I'm excited to give this talk because over the course of my career, I've given so many very detailed talks about certain conditions and topics. And what I realized is we really miss out on the baseline understanding of what psychiatry is. I think this is true in my own experience working with patients and their families, or trying to explain to my friends or my own family what I do. We often get questions like, are you the one who gives medication, or you just talk to people, or where do I go when I want this to happen? And so there's just so much general confusion about what it is psychiatry is and capable of, and what are we even doing. And I'd like to sort of pull back the curtain for you to just get that baseline broad strokes introduction. After we get through the slides, we could go into any sort of questions and details that you want to get into, but let's get started. All right, so recently, in the last 3 years or so, we've been hearing about how we're in a mental health crisis. And does that mean we're in a psychiatric crisis? Does that mean we're in a mental health crisis, or both? And what's going on? And I want to start by defining what mental health is and how that's different from mental illness. So mental health is all about well-being. Someone who is mentally well can realize their potential, cope with normal stressors, and contribute to their community in a productive way. External factors can influence mental health even in the absence of mental illness. These are such things as trauma, discrimination, poor physical health, environmental issues, and family conflict. And as we know, COVID created a large mental health crisis, mostly in the mechanism of environmental disruption. And ways that you can influence and improve mental health from a societal level is stabilize environments, meaning reduce violence. One of the critical pieces is improving education. Whenever you can provide education to populations by increasing knowledge, sharing information, you're directly influencing positive mental health. Okay, we want to provide access to healthcare across all specialties, not just in psychiatric services or therapy services, but for example, we want to make sure people get good prenatal care. As far as that relates to psychiatry, if you have poor prenatal care or an absence of prenatal care, and you have preterm birth or low birth weight, you can have behavioral consequences throughout the rest of your life. So all of the medical specialties are connected, and we want to increase the access to that. We also want to decrease disparities in marginalized groups. So remember, mental health is about well-being. It's about how we think of our potential and how we're able to interact in our communities. It says nothing about treatment. Mental illness are diagnosed conditions that affect emotions and behaviors. The definition is psychiatry is a branch of medicine focused on diagnosis, treatment, and prevention of mental, emotional, behavioral disorders. The leader of the psychiatric team is a physician, that's either an MD or DO, and now because of shortages and how our healthcare model works, we often use extenders that rise to the level of these physicians in a lot of ways. And those are nurse practitioners, psychiatric nurse practitioners, PAs. Okay, the term psychiatry was first used in 1808 by a German professor. And a fun fact, the practitioners were called alienists. These are people who treated mental alienation until the 20th century. And the actual word psychiatry is Greek, which means mind and soul healing, which you'll see later on in this talk has some interesting dualistic problems. as an example of what I'm trying to talk about when we talk about diagnosed illnesses or conditions, right? Let's use sadness for an example. So the whole range of human emotions exists for everybody. And if you're sad, that doesn't mean that you have major depressive disorder, which is one of the very common uh, mood illnesses. And I think because we live in our own brains and we sort of experience things, we try to empathize with people who may have illnesses that you've never experienced, but because you've had emotions, you could say, oh, I think I know what they're going through. Well, let's kind of go through it. So sadness, normal range of human emotion. It could be related to, I just feel bad. It could be something happened at work. You had some stressor, someone broke up with you, all the infinite possibilities of suffering that exist in humanity. But depression is a defined illness of, let's say, 5 out of 9 symptoms for 2 weeks or more every day that causes, and this is the key to mental illness for everything in the diagnostic manual of every possible illness, is it requires a functional impairment, typically something that is a change from your baseline function. So remember, we have all sorts of emotions as humans, and they come and go, and they may not cause a functional impairment, but mental illness does. And that's one of the very key features. In order to be a psychiatrist, this is a medical specialty, so you have to go to medical school. You then, after medical school, match into a residency for, if you're going to be an adult psychiatrist, that's a 4-year program. If you're going to do a fellowship, it's often a 5th-year program. So you can do a consult or addiction or forensic fellowship, that's an extra year. But if you're going to be a child psychiatrist, child adolescent psychiatrist, it's actually 2 years. So you graduate early from adult. You then do 2 years of extended training in child adolescent psychiatry. And the main difference from a practicing standpoint is the developmental histories, I think, matter much more, but really the main difference is the interactions with the guardians and the families of the children you're taking care of, right? So I often tell the residents I'm working with or students that when you do a psychiatric interview in child adolescent psychiatry, you've done 50% of the work if you see the kid. You have to do the other 50% by getting all of the information and having the treatment discussions with everybody else that's involved with that child. Sometimes it's not 50-50, but that's much more involved in child adolescent psychiatry. Everybody who is a child adolescent psychiatrist is also an adult psychiatrist. All right, if you remember one thing at all in this whole entire talk, this is the thing I want you to remember. Anyone can experience times of low mental health. Not everyone has illness. And more importantly, individuals with mental illness can have extended periods of mental health. Just want that to sink in for a minute. The goal of this slide is not to get bogged down in the dates, but is to just give you kind of the understanding of where we've been in the thinking about what this field is. And then really, I want to focus in on how recent the advancements have been in just recent generations. So if you look back like 5th century BCE, mental illness, especially psychosis. So you got to remember, all of the things we're treating have always existed, but they were explained differently. And so back in 5th century BCE, and you could argue some of this carries over even till now, and we'll get to that in a little bit, but these things were considered supernatural. And a very fun example is, like, we don't use this word anymore, but the word lunatic, right, is a description of a manic person who has part of bipolar disorder, which is mania. And the urban legend of werewolves kind of comes from this. They misunderstood how at night these people were acting a certain way, but it was really because they have decreased need for sleep and they were manic. And so I always find it so interesting how literature, urban legends, myths all fit into explaining these natural phenomena that we've always existed with. And so remember, very, very strong hold on supernatural causes, religious causes. Back at that time, as early as the 4th century, Hippocrates started to consider that psychiatric or mental illnesses were physiologic in nature. Now, they were wrong about what those were. They thought they had to do with certain elements, but he started to get to the point of, hey, maybe this isn't supernatural. Maybe there's something physiologic going on. Through the 3rd century, we saw ancient Indian texts exploring psychiatry as an illness. And then beginning of psychiatry as a medical specialty. So we go from 3rd century BCE of just sort of kicking this idea around to late 18th century, you get phrenology. And this is a really cool concept. The whole system of phrenology was that the brain is the organ of the mind, which is a bizarre concept, right? There is no mind, it is just brain. But we have this dualistic idea of there being something separate from the meat that is our brain, because our consciousness makes it feel like there's something to be or something to feel like. So you have this illusion of that self all of the time. But in the late 18th century, you get people starting to say, hey, the brain is the organ of the mind, and the behaviors that we do are better understood from like a neurological standpoint than really philosophical or religious terms. You then have official middle of 19th century psychiatry. This is the stuff from movies and things that we think of with Freud and psychoanalysis and asylums, which served a purpose, but were oftentimes very abusive and probably bad places to be. There was no medication at this time. Sorry. All right, now in the 20th century, you begin to get the biological basis of illness. Lithium was developed in 1948, which honestly isn't that long ago. And then what really changed the game in 1952 is the first antipsychotic medication was developed, and that was Thorazine. So the treatment for schizophrenia actually had a treatment, and it wasn't just some level of incarceration or other sort of barbaric methods that they used at that time. Once we got to 1963, we started to have deinstitutionalization, which carried on throughout the 80s, and this was the beginning of the start of community mental health centers. The idea is that we could start treating people in less restrictive environments, and that would be better if we could keep them in the community, assuming that the care could reach the level that was required to care for people with chronic mental illnesses. Now, it's worth noting that in 1920, in the 1930s, before World War II, before lithium, before Thorazine, academics in Europe started to believe that bipolar disorder, which is a mood illness, and schizophrenia, which is a primary psychotic illness, were actually inherited, and they had a genetic component. But what happened with the Nazi regime is that because of eugenics and the idea of their racist ideology that they were interested in, the genetics of psychiatry was discredited, and the psychiatric research and progress was really halted and eliminated at the time. And it took many, many years for us to even start to open that door again to see that these things actually have a very large genetic basis. The common presentations that we're treating are mood disorders, anxiety disorders, psychotic disorders, trauma-related disorders, personality disorders. So I just want to spend a few minutes just talking about each category a little bit. So mood disorders include major depressive disorder, bipolar disorder, in children now disruptive mood dysregulation disorder. And then each of those illnesses have variations and subtleties that set them apart and have sort of classifications, but those are the major ones. Anxiety disorders such as generalized anxiety disorder, panic disorder, social anxiety disorder, separation anxiety disorder. OCD is actually obsessive compulsive disorder, is not an anxiety disorder anymore. It is more of a impulse control disorder. Psychotic disorders are schizophrenia, schizoaffective disorder, delusional disorder. There's all kinds of variations. Trauma, everybody knows, is PTSD, post-traumatic stress disorder, and its variants. Now, personality disorders is worth a whole course, I think, on its own. But it's worth noting that a lot of times in inpatient psychiatry, where I do my work, personality disorders are very prominent. And what this means is, and there's a number of clusters of them, but this is a little bit different than just a primary psychiatric illness. So if you have depression, you have your baseline, you have depression where you drop down for 2 weeks or more, and then you have a functional impairment, and then it can improve with treatment, or let's say in kids about 8 months untreated. There's problems with untreating, but you get the idea. Personality disorders develop in your early teen years, maybe earlier, and they're persistent throughout your whole life. And the reason they're personality disorders is because the way you interact with the world and the way you acquire information and manage information tends to be maladaptive or pathological. The one most people probably know is borderline personality disorder, or narcissistic personality disorder, or antisocial personality disorder. And they there's a number of classifications, but they're patterns of these interpersonal behaviors that affect you throughout your whole life. They don't just go away with a medication treatment. And a lot of times they cause many problems in your relationships, in your function and work, but they aren't just like, oh, you're depressed and now you're not. The types of levels of care. So we have outpatient, and this is like let's say you start to feel like you're depressed or your anxiety is becoming impairing and it's persistent all the time. You may go to an outpatient provider and go to their office. They will assess you and decide what sorts of treatments you need. And then you would leave and you go live in the world. We then have intensive outpatient programs, which are like group therapy programs that are a number of hours, let's say 3 hours, 3 times a week or so. You have partial hospitalization, which is the next step up, which would be like 8 hours or 6 hours a day of these sort of therapy and psychiatric interventions that you go to in the morning, you stay through the day, and then come back and sleep at home. Then we have inpatient care, which I'm sure everybody's mostly familiar with, especially in Florida, is that these are places that are like ICUs of psychiatry. You're in an acute crisis, and because your symptoms are so severe, they cause you to be a risk to yourself or others, or a self neglect because of them. Now, and we might come back to this when we talk about BayCare Act, but the point here is it's not that you're just a risk to yourself or others, period. It's that the symptoms you have cause those things. So if I'm like, hey, I'm going to get in my car and drive super fast after this talk, I wouldn't go to the hospital just because I did something reckless or dangerous. It wouldn't be because I had a mental illness at that time. It'd be because I made a bad decision. And I think this is why these distinctions are important, because not everything anybody does requires medical treatment. So that's inpatient level of care. Then for people who require either chemical dependency rehab or more long-term psychiatric care, you can have residentials. You see this a lot in adolescent population. And then for adults in the state of Florida, there's still a state hospital. It's very difficult to get in. The wait lists are very long. And this is really reserved for people who are so severely ill, chronically, that they can't really stay short-term in an inpatient hospital, but require really long-term care. And this is, I think we're in an interesting phase where we got rid of all these long-term facilities, tried to go more towards a community model. And I think people are starting to ask questions like, is there a better way to provide psychiatric care long-term for people with chronic illnesses? All right, let's have a little fun here. So you may know we have a problem in psychiatry because people think of it differently than other medical specialties. And it's really hard for individuals, I think, to wrap their head around what psychiatry is, and these sort of negative portrayals, mostly stemming from the long history of believing there's something supernatural. Now, there are three tropes of negative portrayals. One is that the psychiatrist can treat you against your will, right? So if you look at this top right picture, this is a cartoon from the Disney movie Beauty and the Beast. It's one of my favorite psychiatry references, just because it portrays this negative trope so well. Just a little backstory. So if you haven't seen this movie, it's about this beast that lives in a castle and he was cursed, and there's this person named Belle who ends up saving her dad from this castle. She trades herself and whatever, falls in love with this beast. But there's a bad guy, his name's Gaston, and he wants to marry Belle. And so what he does is he pays the psychiatrist, you can see he's holding a coin. He pays the psychiatrist to lock Maurice up and say he's mentally ill and he's insane because he saw the beast. And that way he can try to marry Belle by getting her father out of the way. And the trope is that the psychiatrist gets to say who's insane and can block you away and do things to you against your will. Now, I will reassure you that there's a lot of laws when it comes to involuntary admissions that protect everyone's civil liability, civil liberties, and make sure that everybody's following the rules as far as how this works. So people who abuse their power make good villains, and I think people attribute the power of psychiatry or the secrets that people might give to a provider as if they violate those boundaries would be an abuse of their power. So that's two, right? You're giving them sensitive information. They could manipulate you. And then here's another one that's really problematic. If you look at Hannibal Lecter here in the center, he portrays the trope of, and I'm sure you've heard people say this because people have said it to me all the time throughout my career, is there must be something wrong with you for being a psychiatrist, right? All psychiatrists and all providers are a little bit mentally ill, right? The idea that there's a mentally ill person, acutely mentally ill, doing this job and they can be dangerous is the Hannibal Lecter trope, and that's problematic. Now, as a fourth side note, I just want to point out we have the One Flew Over the Cuckoo's Nest picture, and I just want to dispel this for you. So neuromodulation, electroconvulsive therapy, or now transmagnetic stimulation are some of the most profound and miraculous treatments we have in this field. They're not scary, they're controlled. When it comes to electroconvulsive therapy, you have anesthesiologists present to help do this in a way where the seizure that occurs is not dangerous. And they, again, if we could increase the ability to do ECT, we would help so many more people. It is not what you see in the movies. They're not shaking all over the bed. And it's actually the opposite of the portrayal. My favorite superhero of all time is Batman, and Batman is the best of all of the heroes to display all of the negative tropes of psychiatry and all of his rogues gallery sort of contribute to various aspects of his own personality and his own sort of psyche and how they interact in the world. Okay, now I want to give you a little hypothesis that I have. So we're in a time where for many years of the history of psychiatry, it was a hidden, shameful illness that people didn't want to talk about. They did not want to get care. They wanted to pretend that they didn't have these things. They would suffer in silence, and it was catastrophic. Now, throughout even the last 12 years, I've noticed the stigma of access is gone. I still think people feel funny about psychiatry in general, and I still think, we have our own sort of biases about it. But I've noticed the shift. And I think the things that made people scared of psychiatry, especially the supernatural aspects, have now carried over into what I'm saying is stigma of my another name. And what I mean by that is this. People think that if something happens that somebody doesn't like, somebody does something that maybe doesn't seem good or in line with the worldviews of their families or their communities, that they must be ill, right? We hear this a lot in school shootings and gun violence. We get the finger pointed at providers saying something was wrong with this person, that's why they committed a crime. Psychiatry does not stop crimes from happening. Again, we treat illnesses. The onus of behavior cannot be controlled. And that's where that stigma comes from. The idea that psychiatrists can control you, can manipulate you, can make you do things. That's not real. And that's carried over into this. It's like if I were an endocrinologist treating, let's say, diabetes, and the patient just kept eating cake all the time, and maybe they didn't take their insulin. Is it the endocrinologist's fault that they can't make the person comply? No. And that's the same thing in psychiatry, is you can't make people do things, you can't make people behave. If we had that sort of power, one, it would be a bizarre world to live in, but two, we would empty the jails and we would make sure everybody lived in peace and we all played pickleball for 10 hours a day or whatever. Okay, so to go along with that, right, again, the belief that everything can be controlled or the outcomes can be like if parents bring a kid in, they could say, hey, I don't want my kid talking to this girl and I don't want them dating. And it's like, that is not a psychiatric question. The treatments require people to engage with them. And a lot of times these things require years of treatment. And nowadays, people are less focused on if people are ill or not, but more focused on what they're doing. Are they generating liability? Are they doing things we don't like? Is feeling bad illness? No. So we've moved away from, maybe we never lived in this space, but I'm an advocate for teaching patients, people, children in schools, how to exist in their brains and how to experience discomfort and grow from it and face discomfort and avoid less. The more you avoid, the worse things get. It's reinforcing, right? So we want people to learn to move towards discomfort. That discomfort is the new comfort, and that's just more of a therapeutic technique. All right, a few comments about the BayCare Act. The BayCare Act is the law from 1971 that was created to help establish involuntary commitment to inpatient hospitals in Florida. Now, every state in the country has a variation of this. Some of them have different policies and procedures. The BayCare Act is very unique in some certain ways. But the idea, too, is that this was created to also protect people's rights. That if you didn't meet the criteria for a BayCare Act, you didn't require inpatient hospitalization, which, remember, I equated to the ICU level of care, right? So you don't just go to the medical ICU because you coughed a few times. You have to actually be so functionally impaired that you would require that level of stabilization. And inpatient psych is no different. However, what we're seeing in our lives day to day is that BayCare acts as this cultural sort of meme where whenever someone acts out, whenever someone does something, whenever someone's worried, they're going like to hospitals right away as first line, even though it's the last line of defense. Now, I will tell you, it's going on now. 2 years ago, I was the first person in my team at BayCare to write a bill that changed something very specific in 50 years for the BayCare Act, and that was to allow children to be legally voluntary and their parents consent to a voluntary admission to avoid court hearings and other sorts of things that were not therapeutic. We're not going to go into all the details of that. But the point is that we're very dedicated at BayCare to trying to reform this law, try to make access to care better, and also make psychiatry equal to the other medical specialties as far as making it a therapeutic alliance and less adversarial. Types of treatment modalities. This is something in child psychiatry that I think we have to remember, and it's easy to forget in a sort of instant gratification nation, right? Observation and doing nothing means something. If you could say, hey, let's say we see somebody who's a younger child who's just having maybe some minimal behavioral problems, that doesn't mean they need medication. You don't always need to do something right now. You can wait, you can get more time, you can see things happen. Oftentimes you want to start with therapy first. And now the main difference here is when you do therapy, some psychiatrists do it, but at this point it's really mostly PsyDs, PhDs, mental health counselors, social workers. And therapy is not for everybody. I think we've gone very far with this. It's a very abstract and intellectual concept, and it requires the person be able to engage in thinking at a very high level. So acknowledging thought distortions, which are thoughts that are repetitive, that occur, that are sort of broken thoughts, like, for example, all or nothing thinking. Let's use a simple thing. Like you fail a test. You might say, oh man, I'm a loser. I'm terrible. I'm never going to pass. Well, that's a thought distortion. You didn't pass that test, but you didn't get all the information you needed to make that thought go away or acknowledge it exists and then work to change your behavior as it relates to your thoughts. This is so important that we understand therapy is not something you send somebody to get something you want them to do. Because this is the most common thing I hear all the time is like, that person needs therapy because they're not doing what I want. Therapy, again, this theme of control is when you're engaged in therapy, you're doing very hard work that requires practice to unlearn behaviors and think about how you experience emotions and thoughts differently. And it requires the person to be engaged in that. You can't make them have therapy. We see this come out of certain places sometimes where it's like mandated therapy. You did something and now you have to do this, like, or a bully needs therapy. Wrong, they don't. We're not going to talk about bullies and narcissism now, but the whole idea is, again, therapy is a very, very nuanced intellectual exercise. But in the case where, let's say, you have a child with mild depression, actual mental illness, the first line treatment is not an antidepressant. It's therapy first. If the symptoms get worse with therapy alone, then you require medicine and therapy together. And that's the next piece, is psychopharmacology. We have a number of medications that target various illnesses through different mechanisms. Most cases, you require therapy and medication together. The only difference is in pure ADHD for kids alone, the evidence is that medication works the best. Unless you have behavioral problems, then you need therapy and medication together. And then, as I mentioned before, we have neuromodulation, which is transmagnetic stimulation and electroconvulsive therapy. Okay, last slide, and then we'll do questions. So I want to leave you with this. This isn't even about psychiatry. This is about what I think everyone's onto and trying to get at is satisfaction. And I just want to give credit to this researcher who wrote this equation. So Arthur Brooks is a social scientist at Harvard, and his main area of interest is satisfaction and happiness. So this is it. This is the simple equation. Satisfaction equals what you have over what you want. So if you decrease your wants, you increase satisfaction. So you want to want what you have, right? And if you have kids at home or you have loved ones, you might want to remind them of this, because we live in a society that's sort of marketed to more, what's next, what's around the corner. We need to sometimes stop and want what we have. And that's one of the main keys to satisfaction. All right, so let me pause there. We could stop the recording and then we can let the questions fly and nothing is out of bounds here.